You could?
If I had another life, I would never walk straight. All the things I love to do, other people love to hate. Wear my shoes on my ears and my hat on my feet. Park the car in the kitchen, take a bath in the street. I love ping pong, I love bounce. I love the Three Stooges and those crazy drums. I like lovers who don't vote the same. And lying on my bed in the stars and the rain. Oh yeah. If I had another life, I would run, run, run. Run, run, run. Have some fun. But seriously, if I had another life, I would run for president. Feed the pigeons in the park, never pay the rent. Jerry Garcia, Secretary of State, declares money illegal. Now wouldn't that be great? I love ping pong, I love bounce, anchovy pizza and those crazy drums. I like lovers who don't vote the same. Lying on my bed in the stars and the rain. Oh yeah. Ooh, oh yeah. Now, if I had another life, I would do it all again. Run a movie from the middle, beginning at the end. Try to miss the target and win the biggest score. Tell my dad I love him like I never did before. I love ping pong, I love bounce. I love the honeymooners and those crazy drums. I like lovers who don't vote the same. Talking to my father in the stars and the rain. Oh yeah. If I had another life, if I had another life, if I had another life, if I had another life.
I love that song. That is fantastic. And for all those people that just heard the music, we'll be playing that video at the end of the webinar.
If I had another life, I would never walk straight. All the things I love to do, other people love to hate. Wear my shoes on my ears and my hat on my feet. Park the car in the kitchen, take a bath in the street. I love ping pong, I love bounce. I love the Three Stooges and those crazy drums. I like lovers who don't vote the same. And lying on my bed in the stars and the rain. Oh yeah. If I had another life, I would run, run, run. Run, 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 have some fun. But seriously, if I had another life, I would run for president, feed the pigeons in the park, never pay the rent. Jerry Garcia, Secretary of State, declares money illegal. Now wouldn't that be great? I love ping pong, I love bumps, anchovy pizza, and those crazy drums. I like lovers who don't vote the same. Lying on my bed in the stars and the rain. Oh yeah. Ooh, oh yeah. Now, if I had another life, I would do it all again. Run a movie from the middle, beginning at the end. Try to miss the target and win the biggest score. Tell my dad I love him like I never did before. I love ping pong, I love bumps, I love the honeymooners and those crazy drums. I like lovers who don't vote the same. Talking to my father in the stars and the rain. Oh yeah. Ooh, oh yeah. If I had another life, if I had another life, if I had another life, if I had another life.
We are going to try and start soon. Wait a couple more minutes. Expecting more people. Um, but Nina, that piece of music is good.
Time is all we have, peace is all we need. Stand up again, it's your life and her life, and it's my life. I'm taking it slow, leap from a cliff.
Hi, everybody.
The good wind
We will
blow. This is my life. Put everything on hold. Sit on a bench. Let the
I'm glad
breeze
everybody who's here on time. I appreciate your timeliness and would like to start our program now. So just want everybody to grab a glass of water so they have it nearby. This is an hour and a half, and we do need to drink. And sorry I can't offer you lunch, but I'm hoping that you will have a good lunch at home. So I want to welcome you all to today's webinar, and I am certain that you will be inspired and motivated by all of our panelists today. By way of introduction, I am Susan Lust. I'm Director of PWP, Parkinson's Wellness Project. And we are here to bring awareness, education, and social interaction to people with Parkinson's and their families. I want to thank our hardworking committee for helping us with putting this whole webinar together, and our future ones as well. Our team is inspired by your responses. One of our attendees said to me last week, "How do you find such great speakers? I went to your event in a hotel last year. It took me forever to get there. It was a great event, but I'm so glad I don't have to travel today. I'm so glad you're doing it as a webinar." So I want to tell you how we get here and how happy I am to be part of this whole entity. Our sponsors have been a very big part of this day in helping us put our program together. And they are out in the field and they see what our community needs. And I love brainstorming with them. And I hope they're all here now to hear me because I really want to thank them. As I speak and mention their names, I want you to look at their links by their logos because knowledge is power. And that's why we're doing this. Because we have to know what's out there to help us with Parkinson's. So I would like to thank individually our sponsors for today. From Accorda, we have Elizabeth and Brenda. From Boston Scientific, now you see the links are underneath here, so you could just jot them down. We're working with Layla and Brandon. I hope I pronounced the next one right. From Kiwo Kieran. Couldn't do this without Mike and Kimberly. From Lundbeck, we work with Todd and Charisse. And Supernus, Bill and Allison have been terrific, as you all have. So my sincere, sincere gratitude for working together with us. Now, I would like to introduce you to a close advisor that I met almost 2 years ago, originally from Chicago, where she was working at the Northwestern Medicine Regional Medical Group. She is a board-certified neurologist with 25 years of experience and currently practicing with Dr. Michael Rizak in the New Vance Health Movement Disorder Center at Vassar Brothers Medical Center in Poughkeepsie, New York. So please welcome neurologist Dr. Jennifer Pallone as our host for today's program.
Thank you, Susan, for the introduction and the applause. But really the applause is going to go to everybody today. We have a wonderful lineup, and it's all dedicated to the wellness of people with Parkinson's disease. We want to arm you with options. Of course, when you are at your physician's office, they're going to talk to you about options. But a lot of the important experience comes when you're outside the clinic, and we want to empower you with options to be well, be your best physically, emotionally, mentally. So today we have a great lineup, and I want to just simply say that they're all incredible, actually, and I'm very proud to be part of it, and I learn every time that I participate in one of these events in the webinar. So we actually are going to first talk with Dr. Elizabeth Kara. She is a clinical neuropsychologist, and I'll let her explain a bit more about what that is. But in evaluating our cognitive skills, tied in with our emotional skills and emotional mindset, has a lot to do with how we function, obviously. It's not all just the physical aspects of Parkinson's. So we're going to learn more about clinical psychology, its role in evaluation, as well as developing treatment plan for people with Parkinson's and their families as well. And in addition, we're going to have some unique perspectives on wellness through music therapy. So Brian Harris will discuss with us neurologic music therapy, and we'll learn more about that in just a bit. And then also we have a very special attendee, or actually presenter, excuse me, and that is Nana Bach, who is a Croatian-American recording artist and composer, who's going to talk to us about ping pong Parkinson's. So we will move forward now. If everybody's ready, we'll talk a little bit more about Elizabeth Kara. So Dr. Kara practices as a clinical neuropsychologist at Hackensack University Medical Center. She's actually the director of the Division of Neuropsychology and at the Neuroscience Institute there. She is board certified in clinical neuropsychology. She got her BA in psychology as an honors scholar at New York University in the year 2000. And then she completed her doctorate in neuropsychology at the Graduate School and University Center of at the City University of New York. She specializes in neuropsychological assessments of a lot of different conditions, but in particular, of course, we're going to be focusing on the neuropsychology of what occurs in the brain of a person with Parkinson's disease. With extensive experience in neuropsychology, that can then be evaluated and applied, looking at strengths and weaknesses and how we can improve upon function, developing a treatment plan and rehabilitation recommendations. So with that, I would like to bring on Dr. Elizabeth Kara to teach all of us more about neuropsychology.
Thank you so much, Dr. Pallone, for that wonderful introduction. Let me just say hello to everybody. It's very nice to be here. I am going to start sharing my screen because I do have a presentation as I speak that you will be able to, let me see. Does everybody see my slide show here or?
Yes.
Okay, let me
Yes.
start from the
That's
beginning
very good.
here. There we go. All right, so everybody sees the screen?
Yes.
Okay, great. So I wanted to talk today a little bit about how we maximize our cognitive potential, our thinking skills. You know, I'm going to talk a little bit about what neuropsychology is because most people, including my own family, didn't know what it was before I actually went into it. Most people don't really think about it a lot, but it's something that most people are concerned about. Most people are concerned about how they're thinking, how they're able to express themselves, how they're remembering things. And particularly in our clinical settings, it's something that, unlike the physical symptoms that they might have that accompany their neurologic condition, whether it's PD or otherwise, you know, with those physical symptoms, they can see it, feel it, they know what it is, they know how to describe it. With cognitive symptoms, people don't oftentimes know how to put words to it. They don't know how to describe it. It's something more abstract. It's something we don't see. And so people oftentimes are a little bit more scared when they do notice a change, when sometimes there's not really much to be scared about. So let me talk a little bit about what neuropsychology is first. Neuropsychology is just a fancy way of saying that we're studying the brain behavior relationship. It talks about the way that our brain controls our cognitive skills, our psychological and mental state, our emotional regulation. So a neuropsychologist is typically someone who evaluates those cognitive skills. And the reason that we want to do that is because obviously it's important. Our brain controls everything that we do, from walking, talking, seeing, hearing, making decisions, starting projects. We don't realize it, but those are all kind of higher order human functions that are a little bit more complicated that our brain does. So in neuropsychologists typically look at things like your attention and concentration, processing speed, your ability to learn and remember things. They look at something that we call executive functions. And an easy way to understand what that means is just think about what an executive does. He plans, he problem solves, he multitasks, he strategizes, or she. And so in that way, it's kind of those higher order human abilities that are more complex. That's what executive functions are. Your language skills, your visual spatial skills, sensory motor skills. So we would look at all of that to kind of tell us about brain health. So just like you would go in for an MRI and that MRI can tell a physician about the structure of the brain, it's not going to necessarily tell them about how your brain is working. And so a neuropsychologist typically is the one that would sit down with you and do different tasks that would assess how some of these things are working for you. So I don't want to get too involved in the structures. However, I do think it's important to just touch on this picture a little bit because it tells us about those very important executive skills, especially in Parkinson's. Okay, so in Parkinson's, many of you have heard before that there is a depletion or a decrease in dopamine. And the main structure that produces that dopamine, one of them is right here, called the substantia nigra, and it's right in the middle of our brain, so to speak. We call that subcortical because it's right underneath the cortex. But this little area here has all of these important projections to other structures. You see all these arrows going around in these circuits? And eventually, all of that input, what we usually would get, that input and that electrical kind of activity in those structures from that dopamine that starts to communicate, ends up here in what we call the frontal cortex in the front. And that's the newest area of our brain from an evolutionary standpoint. And that's what's so important about it, is when you think about how we've evolved over the years, we've hopefully become more adept at problem solving and planning and strategizing and multitasking. These are kind of the more definitive things that have improved over time, and they're the most complex kind of functions. And often in Parkinson's disease, because we have a decrease right here in the substantia nigra, in this little area, these projections going into the frontal lobes here, that frontal cortex kind of decreases. And some of those executive skills become a little bit more challenging. So I just thought that that would be a good thing to touch on very quickly, because as we go along and talk about, well, what kind of information do we get from a neuropsych eval? How can we improve those things? A big part of that in Parkinson's disease is talking about this executive control network. And again, those dopaminergic kind of projections from other areas of the brain kind of affect that. So when patients come into the office, the most common thing that somebody says to me is, you know, I really feel like I can't remember things as well. And sometimes they could be accurate. Sometimes it could be a true memory issue. But I think what people oftentimes don't realize is that when they come in and they feel like something's off, I'm not as quick as I used to be, or I'm forgetting things more easily, or I'm not coming up with that word as quickly, or I'm not processing information as quickly. Not all of that means that your memory is off. And I think that the easiest way people have to describe it is, I think my memory is off. But when they sit down with me, they're oftentimes surprised to find that their memory is actually quite strong. It's maybe another area of weakness that's really the culprit of what their concern is. So I thought it might be helpful to go through some of the kind of domains and what they are, so that people can understand, so that you kind of are better informed about what might be going on, thinking and self-analyzing what might be going on, so that if you do ever have a concern, you know how to explain it a little bit more specifically to either your physician or doctor, whoever it is. So one of the first and most basic things that we need for many of our functions is attention, right? We need to actually be able to take in a piece of information and focus and concentrate on it. And I wish it was as simple as just a basic attention. There is basic attention where we just look at something and we're attending to it, but there's also something that we call sustained attention. So your attention over a longer span of time, and being able to focus that attention over a longer span of time without getting distracted. We also sometimes look at divided attention. So my ability to pay attention to two different things at once, but continue to register what's going on within each kind of sphere. Another thing that we talk about a lot, especially in Parkinson's, is processing speed. And so just like executive functions, like we were saying, is one of those common things that's affected, processing speed is another thing that's particularly affected in Parkinson's disease. So just like our movements have slowed, our thinking has also slowed to some extent. And again, that's because of that whole picture of the brain that I was showing you before, that loop that goes on there. But processing speed is just how quickly somebody can process information. And the best way that I kind of explain it to my patients is I say, think about if I just started throwing balls at you, and you have a net that's this big to catch all of those balls. You're going to catch most of those balls in there because you have a wide enough kind of net that would be able to get them in there. But what if I gave you a net this big? Only certain pieces of, information are going to get through there. Only certain balls are you going to be able to catch. The rest of it's all going to kind of fall to the wayside. And so in processing speed, it's that same thing, that same idea of, if I'm speaking super quickly, you may not get all that information in. There might just be some key points that register. So in Parkinson's disease, one of the different tactics that we oftentimes use is making sure that we're speaking just at a regular pace so that everybody can kind of keep up and understand. The most, kind of common domain that I spoke about that everybody thinks is a problem, and that everybody freaks out about if they think it's a problem, and I can understand that, is memory. So in memory, what we talk about is the input of information into memory, so the encoding of it, retaining that information, and then retrieving that information. So it's a multi-step process memory, okay? Think about a computer. You input via a keyboard, you store the information on your hard drive, and you call it back up on your screen or on your monitor. There are, besides those stages of memory, there are many different ways that we divide memory into different kind of categories. We look at memory for visual or verbal information. We might look at immediate or short-term memory versus long-term or remote memory, things that happened way in the past, like when I was 15 or 5. We talk a lot about procedural memory, which is your memory for kind of activities and procedures versus your memory for factual information. So we do look at all those different aspects of memory because it tells us a little bit about what structure of the brain underlies some of these different types of memory when we're doing our testing. And then the executive skills, like we talked about before. Think about what an executive does. He initiates activities, plans and organizes, problem solves, uses hopefully good judgment. You have to be able to multitask, but you also have to have what we call some behavioral regulation. You have to know how to act, right? You have to know what's appropriate and not appropriate. You have to have good inhibitory skills and not be super impulsive. So all of those things are those higher order functions that the newest part of our brain, the frontal lobes, kind of govern. And I like this little cartoon here because I think it demonstrates kind of what many of us take for granted, right? So here's a guy on an interview with someone asking him a question of, do you think you have good people skills? And he says, yes, I think I have good people skills. What kind of idiot question is that? Clearly, maybe not the best executive function. It's a good way to weed out maybe candidates. And then we look at different parts of both speech and then language. And many people talk about the two together, but they're actually two separate things. So in speech, we're speaking about the mechanical aspects of speech, my ability to move my mouth very clearly and articulate very clearly, as opposed to potentially being a little bit more mumbled in speech. The mechanical aspects of speech, like the rate with which I speak, the volume, the prosody, and the inflections, the melodic inflections of my voice, as opposed to just being monotone like this and not really having any sort of emotion in my voice. We look at all of those things, and what we're really looking for, particularly in some of the neurologic conditions like Parkinson's, is whether there's any evidence of what we call dysarthria, or that kind of mumbling of the speech. The movements of your mouth become more difficult to make. Dysphagia, or the difficulty swallowing, whether the speech is fluent or if it's just broken up, and whether there's any what we call dysprosidia, or that monotonous kind of tone in my voice. So that again tells us about the structures that are underlying the brain and what's going on. And then we get to language. So we look at things like your ability to express yourself, so repeat phrases, the ability to name different objects, to generate words. One of the most common things that happens as we age in general, whether you have Parkinson's or not, and this happens to me all the time, is having that tip of the tongue phenomenon. What's that called? Oh, I have it at the tip of my tongue and I just can't come up with it. And some of that's normative as we age, like I said. Sometimes it's not. And again, we would look at that in a clinical evaluation. Receptive language. So we would look at your ability to kind of understand commands and questions from very simple words to very complex passages. And in both of kind of looking at both expressive and receptive language, the lack of your ability to either express or understand what's going on in terms of language and communication would be called an aphasia. So we would be looking for that. We look at different aspects of reading. If one can't read, we call that an alexia, and writing, a dysgraphia. And then we look a little bit at visuospatial functions. So this is something that oftentimes is harder for people to understand and describe. But what really you're looking at is your ability to visually perceive objects and spatial relationships among objects. Common things people will say is, I get lost really easily. Even when I know how to describe where to go to somebody, I'm looking and I can't kind of find my place in space at the grocery store. In driving, they may be getting into more accidents, not motor related, but because they're not judging distances as well, or they may be seeing things that are a little distorted or seeing things that may not be there. So we're looking at your ability to kind of recognize an object or item. We look at also motor skills, so looking at your ability to carry out purposeful movements and your ability to kind of perceive both sides of space equally. And, you know, I put this also up on the screen because I think it's hard for people to understand what these things are like when somebody experiences a deficit in them. But I saw this cartoon and it struck me in what we call an agnosia, or the inability to perceive an object accurately. Oftentimes, patients will see an object, but they don't see it for what it is. They may see a pretzel and they may think that it's a snake. It's not being connected to different areas of the brain appropriately, and they're not perceiving it appropriately. And then we do look at motor skills. So your dexterity, your writing, daily living skills like buttoning, eating, your ability to use those fine motor skills, and then also gross motor skills like your ability to maintain balance or walk, jump, or coordinate. We do a screening of that typically in neuropsych domains. And then many neuropsychologists have kind of gotten away from sensory functions and assessing them. However, they are really important in telling us about brain integrity. So how you smell, how you perceive color, texture. Are there certain areas of sensory functioning that might be blocked? Like, do you have maybe a field of vision that's completely black and you're not seeing something that's in front of you? We do look at some of those things as well. So how do we do these things? I wish I could show you examples on the screen of the actual tests, but they are considered secure by the testing company. So I'd be in a lot of trouble if I showed you the testing items, and it probably wouldn't be fair because then you could practice them before you came in for an evaluation should you ever need one. But they're pencil and paper based tasks. So oftentimes patients will say to me, what does this have to do with what my concerns are? Because it kind of looks like a fun puzzle or a fun game that they're playing, but they don't realize that we've used these tests to detect differences. And we have norms. We have databases basically of what would be normal for someone of your age range, your gender, your handedness, your education level, your cultural status, and ethnicity. And then we look at that to kind of gauge, well, is this something that would be normative for aging, or is it something that's more of a concern? It's more than what we would expect to be deficient in normal aging. And from that evaluation, what we can do is make recommendations. So we may recommend something like what we call cognitive rehabilitation, and I'll talk about that in a bit. Or we may recommend counseling or therapy. Sometimes patients feel like they notice a difference in their cognitive skills, but a lot of it can be attributed to depression or mood issues. And by simply going in for individual counseling for some time, it could really improve their functioning. We may help to consult with the physician so that the physician may have questions about which medications are appropriate given the cognitive concerns, and adjust meds. We may recommend work or school accommodations, or we may recommend some holistic integrative strategies. participating in exercise, yoga, things like ping pong, like we'll talk about later, would be helpful. Meditation and mindfulness, changes in a diet, increasing your social activities. So all of those things would be recommendations that would be looked at. So just very quickly, I wanted to touch on cognitive rehabilitation. So cognitive rehabilitation is a kind of therapy where you sit one-on-one with usually a speech language pathologist or occupational therapist or a neuropsychologist that has been trained in cognitive rehab. And it typically, again, is working either on pencil and paper kind of activities or computerized training or even games like card games, Sudoku. And what they do is they look at kind of the information of a neuropsych and they look at, okay, well, where was the issue? How do we improve that? So you might have thought that your issue was memory, but really it was processing speed, and you're not getting information, into memory. And that's why you think you're not remembering, but what you do get into memory, you remember just fine. So they typically will sit and work on some strategies to improve kind of timeliness of different activities and what to pay attention to, what not to pay attention to. Um, in cognitive rehabilitation, we talk about remediation versus rehabilitation. And both, typically cognitive rehabilitation involves both kind of domains. In remediations, what we're doing really is using your strengths to get around the areas of weakness. But in rehabilitation, what we're trying to do is improve an area of weakness directly. And that assumes some level of what we call neuroplasticity, the ability for your brain cells to take on different roles and wear different hats and kind of strengthen themselves, right? Just like a key part of physical rehab is not just addressing that muscle, but all the muscles that work in tandem around it and that balance it out. It's the same thing in cognitive rehabilitation for the brain. So we kind of put together a plan for the patient of what their area of weakness is and come up with a targeted kind of program to address those issues. To give you a better idea, one of the main things, like I spoke about before, that we kind of look at is executive functions. Patients oftentimes complain, the patients with PD in particular, will complain that they don't initiate activity as much as they did before. They kind of can't plan or organize as effectively as before. They feel like making decisions can be difficult. Time management can be a challenge. Even if they do get started with the project, they keep coming back to the same spot, and it kind of, they get frustrated with it. They may not follow through with the completion of the goal as a result. It creates anxiety for them, and they kind of start to have this, what we call learned helplessness, where they kind of feel like, what's the point? I feel like it's not as good as I used to be able to do it, so why do it? And certainly, while we hear the patient and we know that that must be frustrating, we want them to know that there are ways to improve that, and there are ways to feeling like you are successful, just like you were before. So we typically work on that, as well as kind of the individual self-awareness of progress and success. So one of the things that we may do is work on goal setting. And what we typically do is we take a particular activity that the patient might have, and we don't just pick random ones. We really get to know the patient and say, okay, well, what is it that's been bothering you? What's a goal that you might have had? And one thing, for example, that people might say is, I really wanted to try and invest. I had a patient recently that talked about investing their money, and they had everything in one bulk account, and they wanted to start to become more savvy about it. Now, that's overwhelming for me. Never mind somebody that might feel like getting through the information is challenging. So what we would do is something like come up with a plan, the first of which being to step back and identify a goal. What am I trying to achieve? And the achievement would be, or the goal would be, to come up with a different kind of investment strategy that works for you. They would consider options and alternatives. One option might be something like, let me meet with a financial advisor. Let me talk with my wife and see what our long-term goals are. Are we thinking of retiring in 5 years? If we have all the money in retirement, is it better invested someplace else? Things like that. We might help them weigh through the best options, pros versus cons. Obviously, we are not financial analysts or investors ourselves, so we wouldn't be able to talk about the actual content area, but the steps as to how to approach that. For example, having the conversation with the spouse, setting up an appointment with maybe 2 or 3 different financial analysts, helping them plan out the steps, like picking the analyst that they want, being able to, after they pick the analyst, have 1 or 2 meetings to discuss the alternatives. Coming up with a timeline for each of those steps, breaking it down into smaller kind of areas is really helpful, because thinking about, you know, the whole end goal can be overwhelming, and that anxiety, once it increases, can be counterproductive. It's an obstacle in and of itself. But stopping and breaking it down can make it much more doable and make you feel much more successful once each step is kind of carried out. Trying to foresee other obstacles is helpful, like getting to the appointments. Is it more helpful to have virtual? And these days, thankfully, we have much more kind of experience with having those options, for better or for worse. Then carrying out the plan, but also talking about monitoring progress the whole time, adjusting the plan accordingly. You know, after maybe 2 of the steps, saying, am I still on track? You know, am I still sticking to my timeline? Has something come up that I need to adjust the timeline for? And evaluating and saying, okay, was it successful? You know, each time we have a goal like this with the patient, our goal is to make this be something that's much more of an independent process for them. So we may identify a goal and work through that first goal with them. And the second goal we may help. The third goal we may expect them to do eventually on their own and just check in with them. So it becomes something that becomes much more procedural for them, or automatic, so to speak. You know, one of the things that I think is important to note about the cognitive rehabilitation is that the therapist really plays a key role in helping to structure it and monitor the progress and efficiency. Think about a physical therapist. They know everything about each of those muscles. And once they see that you're gaining a little bit of momentum here, they're going to adjust your exercises and maybe work you a little harder on this side. And so in that same way, a cognitive therapist would work with the patient to adjust kind of their goal setting and plan. Home technology might be used. You know, they might use things like phones or paper planners. Believe it or not, we still advocate paper planners a lot because they're actually quite helpful. Family training may also be required to help improve carryover between the therapeutic setting and the home setting, because the patient may need cues every once in a while, or a little bit of momentum. But the goal should always be to maximize independence eventually for that individual. So this is my last slide. I just wanted to talk a little bit about now, once we have the neuropsych, once we come up with the recommendations, and once we may go through something like cognitive rehabilitation, one of the most common things that people ask me is, so what's the best thing to do? That you know, that what's the best plan for me to keep cognitively healthy? And it's not really one thing. It is really a series of things. It's something that you need to attack at all angles. I always say you need to sleep well. Many of our patients with Parkinson's have a lot of difficulty with their sleep schedules. And so getting that kind of under control, so to speak, is the first step. Because if you're not kind of well rested, you're going to have a hard time accessing your cognitive resources. Eating well, so making sure that you have a healthy and nutritious diet. We talk a lot about the MIND diet, which is basically a combo of the Mediterranean and the DASH diet. The DASH diet is a diet, it's a dietary approach to stopping hypertension. That's what the DASH stands for. So looking at that, that's been one of the most efficacious diets to help with cognitive health. Moving around, so you know, using your physician's or physical therapist guidance as to the safest exercise methods for you, and making sure that you get that exercise. Exercise has been one of the most effective strategies, physical exercise, in staving off cognitive decline. So it's really important to stay as active as you can and can do safely. Spending time with friends, staying socially engaged. For those of you who have family and friends and grandchildren, making sure to be active with them, being mindful and practicing meditation. It resets your nervous system. It's really important. And then using your brain, making sure that you're doing things like Scrabble, Sudoku, Rummy Cube, Bridge, and other card games, ping pong, we'll talk about later, strategic games. I think all of those things are important. Okay. So in a nutshell, I have a feeling that everybody's brain is probably full of my talking. So I'll stop here and let anybody ask any questions that they might have.
Thank you, Dr. Kara.
Did I stop my screen here good enough, or hold on?
Can you?
Let me see. Am I back to my own screen or?
You were before.
Oh, okay. Hold on.
Susan,
Let
can
me
you
see.
hear me?
Yes, we can hear
Okay.
you.
Am I better
So,
now?
yeah.
Okay.
That's good. That's good. So, Dr. Kira, thank you so much. I actually find the neuropsychology totally fascinating. That area of the brain and the intricacies are amazing. Can you just describe for people with Parkinson's what they might expect if I send them for a full I call it
Sure.
neurocognitive, neuropsychological and cognitive? Oftentimes they will come back and they will tell me that it's a very long day. So if you
Yes.
could just comment
Yeah.
just a few moments about what to expect when they come for testing.
So I always say to my patients, I say to them, you know, it's not as invasive as a blood test or an MRI scan. Um, and that's fortunate for you, but unfortunately, it does take me time. It's not as quick. You know, all of these things, like I said, are more abstract cognitive skills, and the best way that we have of estimating them is to make you sit and use them, and to make you sit and use your memory and your language and your attention. It does take time. So a typical evaluation will involve coming into the office. They'll have a clinical interview that lasts for about an hour, and we go into a lot of detail back to how you were in school and how your mom's pregnancy with you was, and all of these different developmental milestones that may or may not have been an issue, all the way through to present day. And then we start the actual testing, which is pencil and paper testing. It's typically the interview. We allow, you know, a significant other or caregiver or a family member to come in the room, friend, whoever it is you feel comfortable with. But for the testing, you're typically one-on-one, because we really need you to not be distracted by other people. And so in that situation, it's just yourself and the evaluator. It typically takes anywhere between 3 to sometimes up to 6 hours. It really depends on the referral question. And sometimes we break those sessions up into 2 different days, because it's a long time to be sitting there. I like to actually ask my patients about their medication time so that I can optimize the testing time and get them at their best. That's really important with Parkinson's. But that's typically what happens. After that, you know, once you leave the office, I always tell them, believe it or not, I spend more time without you on your case than with you. So I have to go back, score everything, look through the medical chart for things that I can correlate with the scores, and then put it into a lengthy kind of report that the physician typically gets, or the patient, and then talk to them about the recommendations.
Right. It is very intricate. Very,
Yes.
yes.
Yeah.
One other question briefly that comes up commonly, and patients will even ask me this, whether or not computer games are a good idea for cognitive work, for cognitive training, or is there a better way to keep our minds sharp?
So I oftentimes say to patients, you know, there's no risk in the computer game, so you can go ahead and play them. However, keep in mind that computer games are pre-programmed. They run on just a select kind of path of different responses they can have to you. And so it doesn't really at least the data or the literature shows that it doesn't improve cognitive skills so much as it improves your ability to play that game on the computer. So with, you know, cognitive rehabilitation, what we really focus on is much more novel kind of ideas to exercising our brain. So things like Sudoku or Scrabble or Bridge or Rummy Cube with friends, usually each response is new. So you're really going to have to think on your feet much more. And those have been shown to be much more efficacious at improving cognitive skills than the computer games.
Excellent.
Yeah,
Thank you. Thank you very much, Dr.
sure.
Kara.
My pleasure.
I want to remind everyone that there is a chat area on your screen, and you can type in questions in the chat section. We may not be able to address all of them during the presentation today, but you can also go on to the website for Parkinson's Wellness Project. There's an area there where you can click on Ask the Docs, and you can actually put questions in. So, you know, there's going to be, I think, a lot of questions in your mind. You may or may not want to put in the chat box today, but certainly you can, when you have some time, you can go on to the website and you can place questions right there for everyone to respond back to you.
Dr. Pallone, I think,
Yes.
Dr. Carroll, we have maybe two more short questions. The first one, is keto diet not good for cognitive?
So I don't know if Dr. Pallone, you have any thoughts on this, but the keto diet I find to be limiting to a certain extent. With something like the Mind diet, it really focuses a lot more on balancing out the food groups. You have legumes, you have green leafy vegetables, you do have proteins that are, really focus more on the omega-3 fatty acids rather than the unhealthy kinds of fats. So I would focus a little bit more on something like the Mind diet for cognitive health. Now, whether or not your physical health requires something different is a different question, and that's why I would always recommend. Many of the integrative centers have nutritionists that will specialize in the particular conditions and providing advice for the different conditions. And I would always recommend a consultation with one. But for cognition, the Mind diet has been shown to be kind of the gold standard. Dr. Pallone, do you have any
Yes,
thoughts?
I agree. The keto diet is very unbalanced.
Yeah.
And it does run basically on the idea that the brain can use ketones. It can use sugar, which is our predominant fuel for our brain through the day, but you can run on ketones. But that's a very unbalanced diet. So I agree. I think that could be a short-term maybe attempt for certain things, but it's not going to be a good long-term strategy for brain health. So. Okay, and there's an additional question about that Mind diet, which can be found certainly by just looking on the internet. There's that diet can be found easily.
Yep, and the Mind diet is basically just a combination of the Mediterranean diet with the DASH diet. The DASH diet is the dietary approach to stopping hypertension. So if you just look up the Mind diet, MIND, you'll find more information about that.
And in general, it's a good heart healthy diet in a way as well, because you're looking at the good oils. You want colorful fruits and vegetables for the antioxidants, low in red meat, very low in red meat, and the like. So you'll recognize it, I think, when you see it. It's a very well balanced diet. So all right, thank you very much again, Dr. Kara. We'll be seeing you again in a little bit.
Great,
Thanks.
thank you.
So I am actually really excited about the next guest as well. Brian Harris is going to talk with us about music therapy. So Brian completed his undergraduate degree in psychology at the University of Maine. He went on to receive his master's in music therapy. He became a board certified music therapist with specialized training in neurologic music therapy. He later did go on and advance his training further. He became one of only 350 people in the world with the distinction of a neurologic music therapy fellow. He actually is also the first neurologic music therapist to be hired at Spaulding Rehabilitation Hospital in Boston. And he is the founder of the clinical division Med Rhythms, which focuses on rehabilitation for stroke, brain injury, and of course, neurologic diseases such as Parkinson's disease. He's actually been a keynote speaker for organizations and centers around the world. So let's welcome Brian Harris to tell us more about the neurologic music therapy and how that can benefit Parkinson's patients as well as any of us to improve our neurologic function.
Thank you, Dr. Pallone, very much. And thank you all for having me and for being here. It's certainly an honor to be here with the panelists, and any time that I get an opportunity to talk about this work, it's an honor to me as well. So thank you very much for having me. And I'm also going to share my screen as I have some slides and video clips to show around also. Can you all see my slides here? Does that work? Great. So as Dr. Pallone mentioned, I'm a board certified music therapist, and I have advanced training in the neuroscience of music and how that can be clinically applied to help people recover things like movement and language and cognition following any sort of neuro disease or injury. Today, we're going to keep it pretty high level in terms of focusing in just on Parkinson's disease. And I'm also going to talk specifically about movement and specifically actually about gait and walking and how music and rhythm can impact walking. And I may touch upon some other points there, but with only a 20-minute presentation, we're going to keep it fairly focused today. But this all comes back to this idea about the fact that music has power. And I always ask this in all of my presentations, can we all agree on this fact that music has power? And undoubtedly, everybody can agree to this concept. And then we think about what kind of power does music have? And many times as we ask this question, we think about music's ability to make us feel a certain way, to change emotion, to change mood, to make us feel happy, to make us feel sad, to express ourselves in many different ways. And that's what we've thought about historically as music as a social science. So in how does music actually make us feel? But now with advancements of neuroimaging, neuroscience, technology, and research, we're now starting to understand music purely through the lens of neuroscience and how we can use music purposefully to improve brain function. And that's what I'm going to focus on today, is really that neuroscience of music. And as we think about this, and all the neuroscience research that I'm going to present today is applicable to 97% of the human population. So regardless of age or culture or ability or disability, everybody's brain objectively responds the same to music. And that's what makes it such a powerful stimulus, particularly in healthcare. And it's a sort of a good timing for this too. And I'd just like to show this as a quick visual, because research in music in the brain is happening at an unprecedented level in history right now at academic institutions and healthcare institutions around the world. And if you go to Google Scholar and you just type in music brain, something very simple as that, and you filter it since 2020, it yields about 20,000 results of keywords that have things that include music and brain. It's an exciting new area and a very promising new area of research. And so it's an exciting time to be doing this. And really the high level principles that underlie all of this is the research that shows, and they've shown this through neuroimaging, about how our brains are globally activated by music. So what that means is it means that when we passively listen to music as human beings, music engages the parts of our brain that are responsible for movement, for attention, for memory, executive function, emotion, language, and movement of all different functions and body functions. And there's actually no other stimulus on earth that engages our brain as simultaneously, as globally as music does. So that's principle number one. And then principle number two is neuroplasticity. So what the research has now shown us as well is that when we engage in music, so engaging in music could be taking an instrument lesson, which I always suggest for folks regardless of age, is to take a music lesson, but also engaging in music being singing. So singing could be in an actual choir, or singing could be in your car or in your shower. That the act of engaging in music, or also the interventions that I'm going to show you about today. So engaging in music aids in the process of neuroplasticity, which is your brain's ability to create new connections or strengthen existing connections throughout your entire life. And so when we think about how globally music impacts our brain and activates our brain, and the fact that it can aid in neuroplasticity, that gives us an incredible new opportunity to help people in a novel and powerful way. And much of this research in how music impacts our brain comes down to how rhythm can engage our brain. And what I'm going to show you here is a very quick demonstration. So if I were there to see you live, which I would much prefer to be than talking to you via Zoom, I would do an interactive demonstration right now with somebody from the audience to show you the immediate impacts that rhythm can have on movement. And I'm going to show you that first, and then I'm going to explain how this is possible. And what you're going to see here is this is a man living with Parkinson's disease in his living room. You'll notice as he's walking that he takes very short steps. He's going to walk over to this chair that you see in the corner here. You're going to see some freezing of gait happen as he begins to turn and tries to sit down. And then as he stands up, he's going to walk back towards the camera, and you're going to notice him actually get stuck a few times, have some freezing of gait episodes, and have a difficulty with initiation. After that, he's going to turn on some music that has a very strong beat that's at an up-tempo song, and you're going to notice immediately how his movement and how his gait changes in response to having the music present. So I'm going to let this play, and then I will explain afterwards.
crazy. That sounds like. Interesting.
So you'll notice there immediately as the music comes on, he's essentially what you think of as dancing. But if you notice literally what's happening is he's turning in circles, he's walking backwards, he's walking forwards, his stride length has changed, and he has no episodes of that freezing that we saw at his baseline video, or watching him walk across his living room. And that is due to a phenomenon in neuroscience that we call entrainment. And entrainment is essentially what they've shown in research is that when we as human beings hear a steady rhythm that repeats in our environment, so something like that music that you just heard, that it activates our auditory system, but also it shows that our auditory system and our motor system, the parts of our brain that are responsible for movement, are actually connected at a subconscious level. And what happens is when we hear rhythm as an external cue that activates our auditory system and our motor system begin to fire in synchrony. So they begin to actually activate together, and that's what we call entrainment. So literally an external cue like music or a song can tell our brain to tell our body to move. And that's something that happens at a subconscious level, meaning that you don't have to think about that happening in order for it to happen. That just as we hear rhythm, it's very hard for us to not actually walk or move to the beat of the music. And I encourage people to actually try this. And the demonstration that I always give is asking people that they should grab a metronome, which is most people are familiar with. You can download a metronome on your app and actually hook it up to a speaker and go to a public park and set the metronome to about 100 beats per minute. And just let the speaker play into the park. And what you'll notice is that as people become within earshot of that speaker, of that metronome, their feet will actually start to synchronize with the beat of the music, even if they're engaging in conversation with somebody else. Because the rhythmic cue is literally telling their brain to tell their body to move in synchrony with that external cue. So this research has been around for a few decades, demonstrating that we can use rhythm to engage the human motor system. In about the mid-1990s, it was translated into a clinical intervention called rhythmic auditory stimulation, which is an actual standardized clinical intervention leveraging that principle of entrainment to help people improve their walking following neurodisease or injury. This intervention has actually been most studied in Parkinson's disease, demonstrating its ability to improve walking function. I'm going to show you here a video because it's a very clear demonstration of the intervention. I'm going to show you a video here of somebody who's had a stroke. And this is showing me delivering rhythmic auditory stimulation with live guitar music and showing the impacts that it can have. It's a pretty short clip. What you're going to notice is you're going to see the person walking without music. So we call that their baseline walking. So this is how they walk around the world. You'll notice that he's using a cane. He's walking very slowly. He has an asymmetry, so one side is not moving the same size or taking the same size steps as his left side. You'll notice that he's walking very slowly. And then we start music. So we start the rhythm of the music at the tempo that that person is walking. So if they're walking at 60 steps per minute, we start music at 60 beats per minute to see if we can get this person to entrain or to walk to the beat of the music. As the person does that and they're safe, we increase the tempo of music by 5% to try to get them to walk faster. And you'll notice how his stride length and his symmetry changes in response to that. Oh, by the way, this video that you're about to see, the beginning of this video is after he's had 3 weeks of physical therapy, 5 or 6 days a week at Spalding Rehab in Boston. And the rest of the video is one 45-minute session doing rhythmic auditory stimulation. So this is one session. So again, this is stroke. This is just a demonstration. You'll notice his short stride length. He's using a cane. He's walking with an asymmetry. We're using pretty simple music. You notice that he's able to walk. So then in the same session, we decided to take the cane away to see if we could get him to entrain between his 2 feet rather than needing to use a cane, which he was using for balance. So this is his first time post-stroke walking without a cane. And then this is after. So just to give a quick demonstration, this is after, the left is after 3 weeks of physical therapy, 5 or 6 days, 1 hour a day. The right side, 45 minutes later. So pretty profound results that we see there. But we do know, and we actually have done a research on this with MedRhythms, my company, where we actually looked at rhythmic auditory stimulation. This is in stroke, showing that we could improve gait speed, but that we could also improve metabolic function. So we could actually improve how much oxygen somebody consumes or uses while they walk, demonstrating that actually as people walk faster or walk with rhythmic auditory stimulation, that they actually walk more efficiently as well as they walk faster, meaning their balance is improving and their biomechanics or their stride length is improving as well. Now, when we think about Parkinson's disease, obviously there are some similarities to stroke gait deficits, but there's also some differences as well. And we know a lot of that has to do to the loss of automaticity in movement. Which is really due to lower levels of dopamine in the tracts that are responsible for motor tasks. And we know that performing well-learned motor tasks can be difficult over time, and that it requires a lot more attention or a lot more cognition to engage or to produce these tasks like walking or moving our arms or more hands that were once automatic. And what the research has shown in rhythmic auditory stimulation for people with Parkinson's disease is that it actually has been able to improve balance, freezing of gait, gait speed, stride length, fall risk, fear of falling, to be able to improve shuffling of gait as well. And this is research that has been replicated, as I mentioned, over the last couple of decades, since about the mid-1990s. What's really interesting is the research that's happened just in the last couple of years in this area, which has shown that actually rhythmic auditory stimulation, and don't worry about this chart per se, but rhythmic auditory stimulation has been shown to actually be able to reduce the number of falls in people with Parkinson's disease. So what they did in this intervention here was they had people do rhythmic auditory stimulation for 8 weeks. Then they removed the intervention for 8 weeks, and then they had them do it for another 8 weeks at the end. And they showed that during the 8 weeks of rhythmic auditory stimulation, that people's walking improved. So stride length improved, their speed improved, and they had less falls. But what this also demonstrated was that not only could you reduce falls, but it also showed that the treatment effect of rhythmic auditory stimulation could be restored when it was taken away, which is very compelling, saying that at any point in time, we could potentially re-administer rhythmic auditory stimulation to receive a treatment effect. Then what they, this is, and without getting too deep in the neuroscience here, I think this is important, that they showed, this study in 2018 showed that synchronizing your movements to rhythmic auditory stimulation actually attenuated dopamine. So decreased dopamine in the ventral striatum, which is part of the brain that's responsible for cognitive attention, which actually showed that while these people were walking or moving to rhythmic auditory stimulation, they required less attention to do so, which is very compelling when we know that we have a higher burden or a higher cognitive load in people with Parkinson's disease to walk. So it could be one of the actual reasons why rhythmic auditory stimulation works in this population. And I get this question a lot. And people ask me very often, well, what type of music can we use for rhythmic auditory stimulation? And there's actually been some really interesting research here that shows that it's actually specific to Parkinson's disease, that music that is high groove versus low groove. So high groove being music that has a strong beat salience. So we think about things like Stevie Wonder or Bruno Mars. These are high groove songs typically, and versus low groove music. So low groove music being songs that are typically slower, more melodic, are typically not good for walking because of that beat salience. So the inability to actually feel where the beats are. But they also showed that doing rhythmic auditory stimulation with music that you like, so songs that you're familiar with or songs that you prefer, actually improved the functional outcomes of walking greater than using music that you didn't like in Parkinson's disease. So that's a very interesting study that was recently done as well. Oh, that's my demonstration. And the great thing about doing rhythmic auditory stimulation is that it can be done anywhere. It can be done in the clinic. It can also be done in home. This is a quick video, but I'm going to skip over this video for today. But this is just a quick video of showing how rhythmic auditory stimulation could be done in the home.
Yeah, be sure.
What I did want to tell you about today is that we are at MedRhythms creating what we call a digital therapeutic. So it's going to be an FDA-regulated medical device that automates rhythmic auditory stimulation. It uses sensors that connect to the shoe and software algorithms to change music to allow people to have access to rhythmic auditory stimulation, regardless of where they are. We've built this product for the stroke population already. And we recently received breakthrough status from the FDA on that product. And we are just in the beginning phases of building this product for Parkinson's disease now, and are in about a month going to be starting a clinical trial with some great hospitals across the country. So we're getting closer to being able to build this product or release this product to people with Parkinson's disease. Now, this science, this neuroscience of rhythm, applies to anything that's motor related. So I mentioned this about walking. It's easiest to see in walking, but it applies to fine motor skills, dexterity. It applies to gross motor skills, or arms or a leg movement. And it also applies to oral motor skills. So even as we think, as Dr. Kira mentioned about speech production, it actually also applies to things like our mouth moving and our tongue moving. And so those things like dysarthria or apraxia can actually be improved by doing them rhythmically or doing exercises in response to rhythm. And so I'm going to end here and just say that, focusing on this takeaway that music, while it makes us feel good, also goes much deeper than that and can have a profound impact on how our brains function. It is connected to neuroplasticity. And also, Susan wanted me to mention as well that we do have a telemedicine service at MedRhythms. So we're building technology to help people improve the way that they walk at home. But we also have a team of clinicians that treat people actually all over the world from afar through telemedicine to help people with Parkinson's disease and other neurodisease and injury improve goals across movement, language, and cognition. So that is also available. This is my contact information, and I'm happy to, we have 2 websites, but this is my contact information, and I'm happy to take questions as well.
Thank you, Brian. That's fascinating. And from a personal standpoint, I'll say that I cannot jog without music in my ear.
Yes, absolutely.
Yeah, right. And again, it's the certain songs that, you know, that really go with your rhythm, with your stride,
And we're
that
starting
help you to
to
keep
now
moving.
understand much more
Yeah.
the scientific validity of that. So why, you know, a lot of times people think about, well, when I exercise to music, it's distracting. I don't feel the pain as much. You know, I go to a different place, which are all very true statements.
Mm-hmm.
But we now are starting to understand that if we use it perhaps a little bit more purposefully in thinking about rhythmic connections to movement, that there could be something very profound there as well.
Right. And I think you already touched on this, but, you know, just the certain style or genre depends upon the person and what their experiences have been over their lifetime and what kind of music is going to stimulate them the best and pull all of the cognitive pathways and together at the same time. So
yeah, we need to look at things like, you know, beat salience. So how well defined the beats are. Can you tap along with the music, and groove, as we talked about, you know, which are important aspects. But then in addition to that, the music that you like typically will yield greater functions than the music that you don't like.
And when you're talking about fine motor skills, I'm sure it's hard for you to simplify what you do, but so if a person were learning a musical instrument, then is that part of the rehabilitation of their fine motor? Depends on what musical instrument it is, I suppose, but could you comment on that?
That's a good question. So when we think about addressing fine motor skills, we use instruments often with not the goal of teaching the instrument, but using the instrument as a rehab tool. So as I think about when we use fine motor skills, we use the piano a lot because the piano is a really great instrument for that. And I always describe the piano as a finger treadmill. So it's not a piano. We're not going to worry about what it sounds like. It's really much more rehabilitation for fine motor skills. And so typically what we do, and also keys are weighted, so there's some resistance there. And when you do it correctly, you get an auditory cue. You hear the sound of the piano. And so we start very basically by providing an external rhythm. So whether that's just a metronome or whether that's actual live music. And then we just try to isolate fingers in time with the music, each finger in time with the music. And then we change the tempo. We speed it up to try to improve fluidity of those movements or slow it down. And then we can isolate multiple fingers at the same time on a piano as well. So there's a lot of things that can be done. We also use a lot of drums as well, picking things up, putting them down, hitting different drums as a way of helping with the fine motor skills as well.
Yeah, it sounds like a lot of fun, which again, you know, the neuroplasticity, the ultimate effect of what you're doing is a fun task, which I'm sure is much more engaging for patients than the standard therapy programs of nothing against, I refer to physical therapists and speech therapists, occupational therapists all the time, but that added fun. I mean, dance, we also talk about with patients, you know, the dancing for Parkinson's as well, which again is engaging what you're talking about, as well as a more general physical conditioning as well.
And we like to think of that, you know, the fun is the added secondary benefit of this. You know, this does not work because it's fun. It works and it's fun. And so, you know, we try to keep it engaging and motivating as well. So.
And then if a person does the therapy, what are the recommendations for an ongoing plan when you've completed your therapy and we turn the person over to say, okay, you're going to continue your home exercise program. So have you taught them a program to carry on at home?
Yeah, so we always try to enable people to keep this ongoing in their daily lives, or I would say, you know, in their weekly lives. If we think specifically about walking, right? So there's frequency and consistency are important for neuroplasticity to happen. Also, we know that as something like Parkinson's disease is degenerative, this is something that's going to need to be done over and over long periods of time. And so, you know, there's a clinical adjustment that happens as people progress, but we always try to enable people to give them skills, whether it's playlists or products or things like that, to practice, you know, 30 minutes a day, 5 days a week, to walk to music, to help keep up with these functional skills.
All right, very good. We have a a couple of questions, and you may want to look at the chat, and then at the end of the program, we can have a little additional time to answer some of those questions. Absolutely. One of them is about the status on insurance coverage for developing a device, which I know is quite a process. And then also one there that about different types of music, like jazz has many grooves combined with sound, and how that might be utilized. And then one last question, just to put from myself, and if I were to suggest to our patients to connect with you. So is that something that really can be done through telemedicine? It's interactive, but they don't have quite as much room necessarily to be moving around. And is that really a good option during COVID?
So telemedicine can be, I mean, I think in relation to the work that we do is a great option. We actually built our telemedicine platform because of COVID. We had started doing it at the beginning of 2020. And then when COVID happened, we accelerated that process. And we found very creative ways to be able to deliver, high quality clinical work via we use Zoom as a platform. But even with limited space, there's still things that can be done. And it's certainly, I would say is worth trying, and certainly not a bad option. So.
One of the factors in telemedicine from my standpoint too, is that you can see people in their environment.
Correct.
You're watching them in their more routine world versus a sterile environment. So I think that actually can be helpful when I see a person navigating around the room in their home. So
it certainly can be, especially, as we think about if we were doing a gait training exercise, right? So you come to a clinic and see us, and we have you walk in an open hallway where there's no distractions and no people and no chairs and no couches. And that's a wonderful place to train. But if we think about the actual applicability of this in real life, it's wonderful to be able to see how you interact with your own environment, such that we can give those feedbacks in the more realistic places there. So.
Very, very interesting. All right. Well, we'll see you again in a little bit. We're going to move on and have Dr. Elizabeth Kara introduce Nanad Bach and learn more about how ping pong Parkinson's came about.
Thank you, Dr. Polone. It's my pleasure to introduce a very good friend of mine, a musician and composer and peace activist. He has sold over 1 million records and has 6+ albums out. He has had the pleasure of playing at festivals like the 1994 Woodstock Festival. He has shared the stage with the likes of Luciano Pavarotti and U2. He's been interviewed by Ed Bradley of CBS and has done a lot of work for peace activism around the world. You can find a documentary film about him featuring him called Everything is Forever on Amazon Prime. But right now what I'd like to do is just talk a little bit about his involvement in Ping Pong Parkinson's, a charity that he founded that is really set up like an integrative rehabilitation method for patients with Parkinson's. So why don't we look, there's a brief video now that we'd like to show, and then we'll get back to talking with Mr. Bach in a little bit right after the video.
People usually say, why me? Like, I never say that, why me? Of course, it's not easy thing to hear. I was diagnosed with Parkinson's in 2010.
It is my very great pleasure to introduce from Croatia, Nanad Bach.
Nanad Bach!
I went around the world twice, just played with symphony orchestra, performed with Pavarotti and Bono and U2 on the stage, and met kings and queens and presidents of countries. I lived my life fully, and I don't know, I inhale life. I've seen people with Parkinson's. It's not easy to observe other people deteriorating. But I never regret that I got Parkinson, because it maybe prolonged my life, because it slowed me down. It's a self-preservation of body, My body knows more than I do. Nobody dies because of Parkinson's. They die with Parkinson's. Somehow I felt that I can do something about it. Yeah.
What made you feel that way?
I really don't know. Maybe eternal optimist. Something that looks impossible to me, it's possible just with time. And that's my strength. Playing ping pong for me means freedom. Free of past, free of future. Once you observe the rotating, spinning ball in the air, you don't think about anything else. It started a couple of years ago when a friend of mine invited me to play ping pong. And then I noticed that next day I feel much better, even cognitive better, and thinking better, and moving better. So I started to play more than once a week. I noticed the difference. That was a breakthrough for me. That was something, it means that I reversed the symptoms. So they called it neuroplasticity. Whether I rewire all the neurons or I created new ones, nobody knows yet. But something happened. 2.5 years ago, I started the Ping Pong Parkinson non-for-profit organization. We have around 10 people with Parkinson and around 10 volunteers. They come like back down, we barely move, and then suddenly they start to play ping pong, and they are smiling, they are running around like a children, You have to see the smiles of these people. You see immediately the difference in people. There's some magic in watching, observing that spinning ball. It's amazing. It's like a butterfly from. It's amazing transformation. There are around 10 million people around the world affected by Parkinson's. We are playing for all of these who cannot play. We want to move things. We want to shake the world, not just shake ourselves.
Imagine all the people living life in peace. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will live as one.
So I want to point out that that short film that you just saw was an official selection in 2020 at the Mountain Film Festival, directed by Brandon Lavoie and produced by Barbara Koppel. I would love now for Mr. Bach to be able to unmute himself and tell us a little bit about his inspiration for putting Ping Pong Parkinson together and how it's helped him.
Hello, everybody. Can you hear me?
Yes.
It's Thank you for this nice introduction. I can't wait to hear myself speaking. So anyway, it was almost by coincidence. A friend of mine, Bob Fearer, invited me to play ping pong at the Westchester Table Tennis Center in Pleasantville, New York, just for fun. And I played, and I noticed, as in the movie it says, I noticed immediately. So I don't want to repeat everything what is in the movie. That's why you saw the movie. But it was a miracle, like music is magic. Music, if Brian Harris said, if this is freeze, this is music. This is flow. Music is flow. If I dance to the refrigerator, I don't shake. So when we move, we don't shake. We shake only when we stop moving. Then we are shaking. But if I move, then I don't shake. So I was lucky. I think today is present Dr. Art Dubois. He's a retired psychiatrist and doctor, and I was lucky to meet him. Meet him at the club, and then it was much easier to form the Ping Pong Parkinson. I coined the phrase in 2015, and slowly I got to Zoran Primorac, who was a 7-time Olympian table tennis player, and he introduced me to the board of International Table Tennis Federation, and I went to Sweden to present my case, and then we organized the World Championship. So now, to cut it short, we'll have 100 clubs hopefully opening next year around the world. There are already 30 clubs in Germany, 15 clubs opening in the UK, and so on. And we also partner with Steve Rowe from UK. We are developing videos to instructional videos, which is very important. And we are developing a new website, which will be pingpongparkinson.org. But all in all, what I didn't conquer the Parkinson, but I conquered the fear, because if you live your life maybe a little bit slower, but you still live your life fully, you have a good life. And why I'm promoting all of this, because there are 10 million people who are sitting on couches and waiting to die. And if we can move these people, there are 3 goals of Ping Pong Parkinson. First is to help as many people as possible, and create an environment that they feel comfortable and happy and fun to play. Second is to engage scientific community to find out why is this hand-eye coordination, reflexes, and all of this, why is this helping? It is helping. I'm 50% better. Let me put it this way: 50% better when I play ping pong. When I stop playing, I'm 50% worse. So to engage scientific community to figure out why is this helping, and hopefully maybe even find the cure. You never know. The biggest inventions came from left field. And the Michael J. Fox Foundation is doing great. They're close to $1 billion raising funds for research. And the third goal is to participate in Paralympic Games, because with Parkinson's there is no classification. Our entrance to all the games is closed. The door. I want to open that door. And also, I want to say that I'm very impressed with Dr. Kerr, how she presented neuropsychology, and also she and Dr. Elana Clark were very instrumental into founding Westwood, New Jersey, Ping Pong Parkinson chapter. So that's what I have to say. So you can ask me.
Thank you, Nenad. Well, the thanks should go to yourself and your colleagues like Dr. Dubrow and your colleague Will Shorts who started it. I think we were just helping get the word out and the message out. You know, the fact that you were able to organize that first World Championships in ping pong for Parkinson's patients. There's been amazing interest worldwide. There are clubs at this point in Germany and other countries. And it goes to show that along with Brian Harris's, for example, treatment, you know, these kinds of methods in rehabilitation, the music rehabilitation, something like ping pong, it points to the need for a multifactorial, a holistic approach to rehabilitation. Sitting in front of a computer and, you know, pressing a button the whole day is going to be boring. It's going to be unimodal, so to speak. It's not going to be a multimodal way of engaging the brain. Something like music, I know, Brian, you had mentioned this before, but the same would go for ping pong and the same goes for the music. It's something that engages multiple areas of the brain together. And it's something that engages, for Parkinson's specifically, motor centers that connect to other areas like the frontal lobe, like all of the, you know, different structures that are so important in targeting those main issues that we have as a result of Parkinson's. So I think it's just fascinating. Nenad, can you tell us and walk us through a little bit about what somebody could expect if they were to come into a ping pong Parkinson's session? So is it just coming in and playing ping pong? Is it something a little bit more than that?
No, it's much more. And also talking about music, Dr. Dubois brought music. At the end of the session, we sing a song. We have lyrics that he prints on a piece of paper. And we also have exercises about whistling, but facial expressions and also juggling. I'll show you a little.
Show us some.
But when you enter as with COVID now, you have a thermometer and we measure your temperature. Wearing mask is obligatory, so you cannot. It's not an option. You have to wear a mask. And we have introduction. Everybody has to introduce themselves loudly because we have one of the major problems with Parkinson is losing the voice. So it's soften. Your voice is softer and softer and softer. And if you exercise and you say your name louder, your muscles are working. So there is a small introduction about the news from last week. Then Art says which session is. We have over 3 years of sessions right now, which is, I think, impressive in itself. That something is continuously doing.
And Nenad, can you tell us how many in the New York, New Jersey, tri-state area at this point?
How many people with Parkinson playing ping pong?
How many ping pong Parkinson locations?
For now, there are 2 only, Westwood and Pleasantville. But we have a spin club. They want to have a program we have in Pearl River. I think that Miss Wilson, I'm not sure, Betty, I think she's also present today. They will be opening. If the COVID didn't happen, we would have already 3-4 clubs opening. But anyway, and then we have instruction. We have a warm-up session. Now we have a coach because we got the support from Parkinson Foundation, U.S. Parkinson Foundation, and now we can afford to pay the coach, additional coach, to have a warm-up and also instructions how to play forehand, backhand, some tricks and so on, how to serve. And then we have session about 45 minutes playing table tennis. And the last table, we have 6 tables. If we need 7, we can go to another room, but we use a robot at the last table so people can play with the robot. And Art and a couple of other people are instructing people how to play. Then we have, when we break up for the juggling, that's also what Art brought to the session. And I can show you, it's very confined space here, but I can show you a little bit what we do. How do it? I don't know if you saw if you see any of this. Do you see that, or Bex? So it is important. We start with one, just like this, jumping from one hand to another, then two, and then three. And so that's for me, it's fun.
And let me just point out, as Nenad's doing this, is that what you're doing is you're engaging motor planning networks, because you're actually engaging the different systems involved in planning out a movement and carrying out a purposeful movement. And that's why juggling is so important. If I can step in and just ask one more question to you, Nenad, before you go. I know you and I talk about this all the time, but besides just the neural focus of the rehabilitation, the actual movements, the voice projection, the stretching, the juggling, there's another important piece of this that many people overlook, and it's that social piece. Can you speak a little bit about that?
Yes, people come sometimes with the long face and leave with smiles. They're like children chasing the ball, and also they're among their people. They're not judged for what they're shaking or something. We stumble with our words, so we understand that. So it is very socially acceptable to shake. I want to mention also that we are preparing a book with Warren Rosenberg, who is a photographer who photographed the World Championship, and we have illustrations by Ignatius Blanc from Barcelona. That the title of the book will be Ping Pong Parkinson. It started with a tremor and shaking up the world. And I have how to say, illustration I can show you quickly, just for a moment. It's a background. It will be my background. You cannot see my head well, but you can see the background. That's illustration, and
Amazing.
I love it. And so it's social aspect it's a support group. Became not just table tennis. It's a support group, and we have great people, all walks of life.
I would say that one of the things that I've noticed in coming is that it includes all ages, which I think is really important, because a lot of times patients that are younger will say to us, I really need something that's a little more active, a little more engaging. I don't want to feel like I'm just coming into a boring PT session every week. I want to be able to engage a little bit more, and that's been something that's been really important. So I think that, as I imagine, the music therapy too incorporates some of that social involvement from other people that are around them eventually. I think that piece of it for Parkinson's patients, for individuals living with Parkinson's, of reintegrating in different ways into social circles, it's really important. So for all those that are interested, please do log on to look for pingpongparkinsons.org and to look for more information. I hope that you've all really enjoyed some of the presentations that we've given. I pass it back now to Dr. Pallone and Susan.
It's also pingpongparkinson.org, not
sorry,
not
I should be more careful. Yep, pingpongparkinson.
I noticed that as well.
Yeah.
Sorry.
Because there is we are not dependent. Apostrophe S is dependency. So there is a psychological also reason, and also it flows better.
Okay.
Anyway, in the book there is 2 pages of explanation why not S. So, thank you,
Thank you,
Elizabeth.
I think that this has been an incredible presentation, and I just want to thank all the panelists today for joining us. And I would just like to give first a round of applause to Dr. Kira for joining us. And I'd love to give a round of applause to Brian Harris. Fantastic.
Yes, very fun.
So much from both of you.
Very good.
And now, Doc, you are used to applause, but we want to applaud you for what you were doing for all of us. Thank you so much. And Dr. Cologne, you have been wonderful. I hope you will come back and do it again with us.
Thank you. Always fun. Always good to learn.
And now you take it away.
All right. Okay. I want to also applaud all the participants, all the audience, those that are trying to find good ways to help themselves. Positive attitude matters so much. When you come to webinars, you learn more about your condition, about the illness, but at the same time, you want to get that positive attitude. There are treatments, there are positive things, there are empowering things that you can do to help with your wellness. And I thank the Parkinson's Wellness Project, Susan, everyone behind the scenes for making this possible. Thank you. Thank you.
As we leave, we want to play one more music video that Nanab wrote. It's the official music video for King Kong Parkinson. And after that video, Dr. Pallone.
Yes, I just want to remind everyone there will be a questionnaire at the end of just after the video, and it really helps to build the future programs and get your ideas of your experience with the webinar today. So please look for the questionnaire and complete that. Thank you so much.
Thank you.
If I had another life, I would never walk straight. All the things I love to do, other people love to hate. Wear my shoes on my ears and my hat on my feet. Park the car in the kitchen, take a bath in the street. I love ping pong, I love bums. I love the Three Stooges and those crazy drums. I like lovers who don't vote the same. I lie on my bed in the stars and the rain. Oh yeah. If I had another life, I would run, run, run. Run, run, run. Have some fun. But seriously, if I had another life, I would run for president. Feed the pigeons in the park, never pay the rent. Jerry Garcia, Secretary of State, declares money illegal. Now wouldn't that be great? I love ping pong, I love bums, anchovy pizza, and those crazy drums. I like lovers who don't vote the same. Lying on my bed in the stars and the rain. Oh yeah. Ooh, oh yeah. Now, if I had another life, I would do it all again. Run a movie from the middle, beginning at the end. Try to miss the target and win the biggest score. Tell my dad I love him like I never did before. I love ping pong, I love bums. I love the honeymooners and those crazy drums. I like lovers who don't vote the same. Talking to my father in the stars and the rain. Oh yeah. Another life. If I had another life. If I had another life. If I had another life.
Thank you, everybody. Come back November 1st.
Thank you, Susan.
A pleasure. All of you have been a great pleasure. Thank you.
Thank you, Susan, very much.
Bye-bye.
Thanks again, Susan, for organizing.